Hello, everyone. In this session, we are going to study the biliary tract diseases. First, let's have a look at the cholelithiasis. Cholelithiasis is what people usually call gallstones, also often referred to as cholelithiasis. It refers to the calculus occurred in the gallbladder, biliary duct, etc. In terms of the clinical classification, cholelithiasis is divided into cholesterol calculus, pigmental stone and other calculi based on the composition. The first one, cholesterol calculi, include mixed calculus and pure cholesterol calculus, with 80% inside the gallbladder. They are round or oval in shape, light yellow or grayish yellow, smooth on the surface, and have radial grains on the tangent plane. Cholesterol calculus is not developed on the X-ray plane film. The second one, pigmental stones, are divided into pigmental calcium stones and black pigment stones. Pigmental calcium stones are soft-structured, fragile, brown or taupe, and also known as brown stones. They often occur in various levels of intra- and extrahepatic bile ducts. While black pigment stones are hard-structured and almost all occur in the gallbladder. The third one, other calculi, comprise calculi with rare composition, such as calcium carbonate, calcium phosphate, etc. According to the position of calculus, cholelithiasis is generally classified into cholecystolithiasis, extrahepatic biliary duct stone and intrahepatic biliary duct stone. Now, let's talk about the cholecystolithiasis. Cholecystolithiasis is common in adults, particularly adults at the age of 40-50, women, obese people and pregnant women, and the man-woman incidence is 1, 2, 3, 40, 50. Its incidence is high in regions popular with high cholesterol foods. The calculi are generally cholesterol calculus or mixed calculus, mainly composed of cholesterol and black pigment stones. The formation of cholecystolithiasis is related to lots of factors. Any factors that change the ratio of cholesterol concentration to bile acid phospholipids concentration and result in the cholestasis can lead to the formation of calculus. Most patients are asymptomatic and only identified at the time of a physical examination, and such cholecystolithiasis is referred to as asymptomatic cholecystolithiasis. In some patients, the typical symptom of cholecystolithiasis is biliary colic and present as acute or chronic cholecystitis. In clinical cases, the typical symptom of patients is first the biliary colic, that often occurs in the right upper quadrant or below the epigastric xiphoid after taking a rich diet, with paroxysmal aggravated pain. Radiate into the right shoulder and the back, accompanied by nausea and emesis. It sometimes occurs at night. Since the first attack of the biliary colic, it reoccurs in about 70% patients. Second, dull pain in the right upper quadrant. Most patients feel a dull pain in the epigastrium or the upper right quadrant only when they eat too much or eat fatty foods, are under a pressure in work or do not have a good rest, or when they suffer a glutted discomfort, belching, hiccup, etc., and are prone to be misdiagnosed as a stomach disease. We should be very careful about that. Another special clinical manifestation is known as Merizzi's syndrome. Merizzi's syndrome is a complication in which, due to the excessively long concomitant ductus cysticus and common hyptaic duct, or due to the excessively low junction of ductus cysticus and common hyptaic duct, A large gallstone is continuously incarcerated and compressed in the cystic duct or neck of the gallbladder, causing compression of the common hepatic duct or fistula of the gallbladder and the bile duct, resulting in recurring cholecystitis, cholangitis and obstructive jaundice merisy. Other manifestations include secondary cholangiolethiasis, biliary pancreatitis, and white bile occurred in hydrocholecystis. That's all for the clinical manifestations of cholecystolethiasis. And next we will talk about the diagnosis of cholecystolethiasis. By combining the typical clinical manifestations with ultrasonography in diagnosis, the correct diagnosis rate could be higher than 95%. CT and MRI scans can provide further assistance. As the chronic irritation of calculi to the gallbladder mucosa may result in gallbladder inflammation and even canceration, and the laparoscopic cholangiotectomy has been widely applied and achieved good curative effects. For symptomatic and complicating cholecystolethiasis, the cholecystectomy shall be carried out in time. It is best that the operation is carried out at the remission stage after the acute attack of symptoms. For patients in poor general conditions or in critical conditions, or unable to withstand a lasted operation, or during the operation, there is local serious adhesion or an unclear anatomic relationship. The cholecystostomy may be carried out in the first place. For asymptomatic cholecystolethiasis, periodic checkups and observations shall be made, and no immediate operation is required. In the case of the following conditions, the surgical treatment shall be considered. 1. Calculi large in number and diameter 2 to 3 centimeters. 2. Calcification of gallbladder wall, or porcelain gallbladder. 3. Accompanied by gallbladder polyps 1 centimeter. 4. Thickened gallbladder wall, 3 millimeters, that is patients with chronic cholecystitis. When the cholecystectomy is in progress, a common bile duct exploration shall be carried out in the case of the following conditions. 1. The preoperative health history, clinical manifestations or the imageological diagnosis has proved or imposed a suspicion on obstruction of the common bile duct, including obstructive jaundice, choledocholethiasis, recurring biliary colic, cholangitis, and pancreatitis. 2. It is proven during the operation that there are pathological changes in the common bile duct, or calculi, roundworms or lumps are proven through the cholangiography or reached during the operation. 3. The common bile duct has dilated for more than 1 centimeter in diameter. The duct wall thickness has increased apparently, and the pancreatitis or lumps of the pancreatic head have been found. Purulent or hemorrhagic bile or silt-like bile pigment particles are extracted through puncture of the bile duct. 4. The gallstones are small, and may enter the common bile duct through the ductus cysticus. To prevent any purposeless common bile duct exploration and unnecessary complications during an operation, we may perform the cholangiography or the choledocoscopy during the operation. After the common bile duct exploration, a T-tube shall be embedded for drainage.
Thank you for coming to the class. See you.